and welcome to Power Hour. Today we're discussing neuropsychological assessment, and hopefully I'm going to be able to give you all some insight into what a neuropsychological evaluation is, why it matters, how do you get one, how do you understand one, and then what do you do with it. Today's presentation is sponsored by UCB. They are now the corporate sponsor of our Power Hour events. We're really thrilled to have that support. The Pediatric Epilepsy Surgery Alliance is an organization that's been around for 11 years. Our mission is to support children and families of those who have had epilepsy surgery or anywhere on the epilepsy surgery journey. And our goal is to help the child or adult reach full potential after epilepsy surgery. And we have numerous resources on our website, which you can check out. And I'll be sharing a number of resources with all of you after today's presentation. I should have said one thing about me, just so you know who I am as your presenter. My name is Audrey Vernick. I'm the Director of Patient and Family Advocacy for the Pediatric Epilepsy Surgery Alliance. I'm also the mother to a 19-year-old who had hemispherectomy for stroke in utero and infantile spasms when he was 2 years old, and he's now 19 and in college. Our next Power Hour is on May 9th, and our speaker is Dr. Janelle Wagner, and she's going to be talking about behavioral health wellness in teens after epilepsy surgery with a focus on things like depression and anxiety. So how do we talk about assessments? It's a really, really big topic. I put this presentation together. I shared it with, we have a volunteer education working group that helps me review content. And the comments were, wow, this is a lot. So I'm going to apologize in advance. I am not going to talk about every slide that I have because I do want to allow time for questions. I will share my slide deck with my notes with you after today's presentation. So you will have all of this. So if you don't want to be furiously taking notes, you don't have to. You can just sit and listen. I want to start by reminding you that we have IEPs after epilepsy surgery webinar series on our YouTube channel. If you haven't already watched it, it's a very important 5 hours of your life. And it really gives you the foundation for this process, the IEP process. Where we are today is in the assessment process. That's what we're talking about today because neuropsychological assessments fall under that. But I also want to remind everyone who's listening today that a neuropsychological assessment is not just important for the IEP process. So you might have a child that is in preschool or has graduated from school or is homeschooled or is in a private school. So we frame a lot of our conversations around the IEP, but for today's presentation, it doesn't really matter if you have an IEP or not. All right, what is a neuropsychological evaluation? So as a parent of a child who's had brain surgery for epilepsy, we need to understand our children. And this is true, again, regardless of where your child is in school. It doesn't matter. It's not about school. It's about knowing about your child and what supports can be put in place for them to help them. How can you determine the best interventions for your child? The best curriculum, the best learning environment, behavior strategies, etc. Is that something that you can do? Or do you need support with this? Should someone who knows nothing about epilepsy or epilepsy surgery be making these decisions, which is often the case in school-based assessments? No offense to any school-based assessor who might be watching, because I think there might be one here. What about someone who doesn't know your child at all? Should that person be making decisions about the best interventions for your child? Will a one-size-fits-all approach work for your child? Like, this is how we do it here. This is the way it's done. And why or why not? Why would that work? So I always like to start by asking, who is the expert in the child's condition? And all moms and dads out there are like, me. I'm the expert in my child's condition, right? We know that. I know I am the expert in my son's condition. But you have to, if you are really going to be the expert, you need to know how your child's unique brain works. You need to know what impacts your child might be facing based on their epilepsy, the underlying condition that led to epilepsy surgery, their epilepsy history, any other conditions. You have to know what are the best intervention strategies to use with your child that are evidence-based and that work for kids with your child's unique profile. And how will these interventions work for your child's unique combination of strengths and needs? So these are all things that a neuropsychological assessment can help you learn about. And the evaluator will also rely on parental and family input via interviews, rating scales, and more. So as the parent's voice in the process of assessment, you are part of it. You get to ask questions of the neuropsychologist, you get to be interviewed, you get to fill out the rating scales. So you are still having a say and a voice, but you're having it framed by an expert who really understands the brain basis of the disorder. I'm going to talk about this a little bit later, but I just want to start by reminding everyone the International League Against Epilepsy, which is an international organization, states that neuropsychological assessment should be part of the pre- and post-operative evaluation of all epilepsy surgery patients. Really, really important to think about as we go forward here, right? It should be part of the process for every patient who has epilepsy surgery. There are so many different types of brain surgery, and I don't know which type of brain surgery any of you had, and I don't know your child's specific injuries, disabilities, et cetera, but that is up to you to research, because remember, if you're going to be the expert in your child's condition, you need to know all of this. This slide shows what different regions of the brain do, and you might say, oh, my child had a parietal lobe removed. That means they're going to have issues in perception, making sense of the world, arithmetic, and spelling. Maybe, maybe not. The other thing we have to remember that is the brain is truly a system of networks that's all connected and talking to each other all day long. So while the occipital lobe is responsible for vision, that's where the brain sends visual information for processing initially, but then it immediately sends it to the parietal and temporal lobes, depending on what type of visual information it is, for what it's going to do with it. The visual networks are very, very complex in the brain. They're now finding that with attention deficit disorder, executive function disorders, et cetera, it used to be thought, well, if you had a frontal lobectomy or a hemispherectomy or TPO, or sorry, not a TPO, anything that affects the frontal lobe, you're going to have an impairment in executive function. But now they are saying there's actually an executive function network. So it doesn't matter which region of the brain is impacted, all the regions can be affected. And it gets more and more complex. So that was kind of a simple view. Here's a very complicated slide. There's a lot to know about the brain. So do you want the person evaluating your child and helping you understand their strengths and weaknesses to be an expert in the brain and how the brain functions? Do you want them to be someone who also understands the effects of anti-epileptic drugs, the actual manifestation of your child's seizures, so the underlying condition like stroke or Rasmussen's encephalitis or hemimegalencephaly or tuberous sclerosis, and then the effects of their epilepsy surgery? I feel very strongly that you need an expert who understands the child's brain functioning and cognitive processes, thinking, memory, processing information, and their ability to regulate behavior associated with their brain-based conditions. So the why and the how, not just the what, in order to design a relevant educational plan or even a plan on how to participate in family or community life and to help them find appropriate supports for their daily lives. So the neuropsychological evaluation focuses on the relationship between the central nervous system, which is the brain and spinal cord, and mental functions and then behaviors as a result of that. Neuropsychological tests will examine the brain's ability to carry out these functions. So we're looking at language, memory, perception, or attention. It'll help assess the impact of surgery and any changes in seizure control on cognitive development. It can help the family get a better picture of the child's strengths and weaknesses and help set expectations for the child at home and at school. And for most children after epilepsy surgery, the results will be compared with pre-surgical testing to determine whether surgery changed the child's skill pattern or rate of development. I'll discuss this a bit later as well. Then it also should be comparing, it should be comparing with previous evaluations as well, which may or may not be available. So this assessment is going to provide the most comprehensive picture of your child's cognitive and learning profile, describing how the brain processes new and novel information, describing strengths and weaknesses in detail. A neuropsychologist can diagnose conditions such as autism, attention deficit disorder, intellectual disability, specific learning disability. A school evaluation, so a psychoeducational evaluation, they can only identify an eligibility category. So they are not diagnosing the child with dyslexia or autism or a specific learning disability. They are assessing them for eligibility under one of IDEA's 13 eligibility categories. So if you go back and watch that webinar series I talked about before, it'll discuss and we discuss in detail the eligibility categories. One thing that I hear a lot, and I'm going to talk to you about this throughout today's presentation, is I don't want you to be afraid of the neuropsychological evaluation, really, or any evaluation. I know sometimes parents don't like diagnoses. They don't want their child labeled, right? We don't want, it's like, oh, really another thing, another thing to add to the list of what's going on with my kid, right? They don't want their child labeled with ADHD or autism spectrum disorder, intellectual disability, or whatever. I understand that, but remember, the diagnosis may change over time with development. It's not a tattoo or a brand that's lifelong. The important thing is that it buys you an in for specific services for your child. It gets you supports and interventions that the child might not otherwise be eligible for. This is really important at transition age. I've seen several young women in particular that are diagnosed with autism late, like in high school. And then that opens up the door for a world of services in adulthood that are only available for individuals with autism, for example. This assessment is also going to determine the child's level of functioning. So if you have a 10-year-old child, you want to know, is she functioning at the level of a 10-year-old? Or is she functioning at the level of a 2-year-old? Or is it somewhere in between? I'm going to talk about how assessments are not normed for our kids. So there's a lot of caveats here, but in general, it can be very useful in educational planning for students with neurodevelopmental disabilities. It's more extensive than an educational psychological evaluation because it assesses all areas of functioning. And also it should be providing detailed recommendations in each area, sort of a roadmap for you and the school team, if you're using it that way, to follow. So there are a lot of challenges after epilepsy surgery. I'm not going to read this slide to you, but you get the idea. What you want to think about, what are your child's impairments? I'm going to be sharing a document with you after today's presentation that includes language you can use to send a letter to the neuropsychologist in advance, or an email or a conversation to say, these are the concerns we're having about our child, so that then they can be sure to look at these areas in their evaluation. So you can help shape the focus of the evaluation by stating what the concerns are. A lot of our kids who have had any motor strip impairment will have difficulty with writing, but there are other mental processes that impact writing as well. So there might be an expressive language disorder that impacts their writing ability, that is more of a brain-based challenge rather than just the pure motor. A lot of our kids have central auditory processing disorder, while a neuropsych evaluation won't, oh my goodness, my slides are going crazy here. While a neuropsych evaluation won't, they can't assess for CAPD or central auditory processing disorder. They can indicate that there might be a concern in that area and then refer for further evaluation. So there are many areas here, as you can see, and it really is just going to depend on what are your child's issues, what are you asking the evaluator to look at, and then they're going to determine what the appropriate evaluation areas are. In general, these are the areas that a neuropsychologist will consider in their evaluation. So they're going to look at reasoning and intellect. So they may do an IQ test or do measures of cognitive ability. There's memory and information processing, and attention and executive functions. Those are in bold because those are the areas which I see in my work with families and that I see in the literature that are the most impaired in individuals with epilepsy. Forget surgery, forget underlying condition. Epilepsy, period, can impact these areas. And other areas that the neuropsychological assessment may touch on are speech and language. So there's lots of language functions. So again, they're not doing a speech and language evaluation, but they're going to be looking at different domains and deciding, do we need a further workup here? But they're going to be looking at cognitive processing deficits related to phonological segmentation of words or difficulty in decoding or language comprehension, right? And then what academic areas might be affected by these weaknesses, like basic reading skills or written expression or listening expression, math problems that are encoded in language. Social cognition. So it was not routinely tested. I think this is changing. It's being increasingly recognized as relevant to the assessment of people with epilepsy. And it includes processes such as understanding and managing emotions in a social context, which I'm sure a lot of you are nodding, right? How many of our kids have challenges understanding and managing emotions in a social context, right? And then theory of mind is another area that is increasingly being evaluated in these individuals. Sensory and motor functioning. So they want to look at auditory function. So again, they're not going to do a auditory processing evaluation per se, but they're going to note some of these functions. They're going to look at visual spatial processing, all different kinds of subcomponents there. They're going to look at academic skills like reading, writing, and math achievement, adaptive skills. So they should be looking at adaptive functioning and determine how any of the brain dysfunctions impact the ability of the individual to complete day-to-day functioning in their routine environments. Looking at behavior. So what are their coping strategies? What self-regulation skills do they have? And then social emotional concerns. Also widely known in the literature is that mood disorders such as anxiety and depression are very prevalent in individuals with epilepsy. Not necessarily, there's not as much research in epilepsy surgery, but we know in the population of individuals who've had epilepsy, there's a very high incidence of those social emotional concerns. So there's standardized measures, which I'm going to share with you, and then there's also information gained from other sources. So often before any evaluation is done of a child, hearing and vision tests are performed to make sure there isn't a deficit in one of those areas causing the child's struggles, right? Whatever reason you might be wanting to do this evaluation. These screenings look only at acuity generally. So they're going to look at peripheral hearing and they're going to look at, acuity in vision, which are not the same as a central auditory processing disorder or a cortical visual impairment assessment. For our kids who have the brain basis of a disorder, those should also be conducted. It doesn't rule out the need for a neuropsychological evaluation if you have one of those conditions, but it can inform the evaluation. Parents and the student, if appropriate, are interviewed. They'll complete questionnaires. I highly recommend that you provide a list of concerns ahead of the assessment. Again, I'm going to share a sample document with you. A developmental history is gathered. The teachers and the parents complete rating scales. I generally ask for at least 2 different teachers who know the child at school to be able to fill out a rating scale because often their responses are wildly different. And then all of the records are reviewed. So the IEP, all other academic records, medical records, et cetera. And there should be a behavior observation. Sometimes it's done in the context of testing, but other times a neuropsychologist will want to see the student in a more natural environment or even in their school environment. It's usually 2 to 8 hours of testing, depending on the child's age and ability to participate in testing. So quickly, I'm not going to spend a lot of time here. And again, I'm going to share these slides with you. I'm going to share some different measures that might be used in a comprehensive neuropsychological assessment. The determination of which measures are used are determined by a skilled evaluator. So you're going to find an evaluator that's knowledgeable about the brain and disorders of the brain and epilepsy surgery, and you're going to trust them to be selecting the right measures to use with your child. We do have an educational assessment checklist, which I'll also be sharing that link with you. And all of these are listed there with more detail. So I'm just going to quickly go through these and just kind of to give you an overview of some different assessment measures that might be used. Some of these names might be familiar to you, but if you don't know anything about an assessment measure that's being used on your child, and this is true outside of the world of a neuropsychological evaluation as well, like a Kaufman assessment battery is a pretty common test, or a KTEA, a Kaufman test of educational achievement that's used in academic settings, or Woodcock-Johnson testing, right? If you don't know what it is and what the test is measuring, research it, find out about it, or ask the assessor to give you more information. That's true of any assessment. They're going to look at academic They're going to look at language. So here are some of the language measures that might be used. They're going to look at auditory function. Again, it's not the same as a full central auditory processing evaluation, but they're going to look at how are they using their auditory skills. That's listening, comprehension, receptive language, even acuity, auditory acuity. They're going to look at visual motor skills. So they're wanting to know how are they able to use their hands and their eyes together or not well or not well. They're going to look at executive function, attention and executive function. They're going to look at nonverbal intelligence. So this will be done true of students that speak and those that don't speak, right? So my son, who had a right hemispherectomy, has a nonverbal learning disorder. So his nonverbal intelligence is quite low, but his verbal intelligence is quite high. So these measures would be used in both populations, just depending. So I want to spend a minute just talking about IQ, because I have parents say, I don't want my child to have a neuropsych assessment because I don't want them to measure my child's IQ, right? So you can request an assessment in processing areas only and ask that IQ not be measured. And if you have an evaluator that's saying, no, I won't do that, you can find a different evaluator, right? You're the client. And the other thing about IQ is that it only tells us how much a student knows within the range of developmentally typical intelligence. So it just tells us whether the child does or doesn't have a cognitive disability. It tells us very little about how a child will respond to interventions. So some of my favorite reading experts like Kathleen Whitbread and Jill Allor and oh my God, there's Karen Erickson. They all talk about how even children with very low IQs, children with Down syndrome, below 40 IQs, untestable children, can still read. So how is that, right? It's because IQ and performance are not necessarily correlated. We want to know how the child will respond to intervention more than we care about IQ. IQ can be helpful, but it's not the only factor in these tests. The other thing to remember is all these standardized tests that I just showed you, they all come with interpretive guidelines and norms. They've all been tried out on children of different ages. So we know what a typically developing 3-year-old would do on this test and what a typically developing 6-year-old would do on this test. So the neuropsychologists will use that as a basis for comparison. In our kids, all IQ tests would be estimates because they have to break protocol to assess our kids. There are no IQ measures that I know or standardized measures that are normed for individuals with visual, auditory, or motor impairments. So all testing will require them to break protocol, which is why you want a really skilled evaluator who can say, let's do this measure timed the way the measure is supposed to be done, did poorly. Let's see what happens if we do a similar measure, but not the same one for test. We don't have a test remembering test, that they remember test bias because they've already seen those questions, but a very similar battery, and we'll give it untimed. Oh, look at that. When this is untimed, this kid does great on this same measure. That is a lot of great information to share with the school team and say, don't give my kid timed tests, right? So does the fact that these tests are not normed on kids with visual, auditory, or motor challenges mean we don't do them? No. We need to be very careful about how the results are interpreted and that we use multiple measures for children with these needs. But we want to make sure we get a complete picture of all their needs and challenges. We just have to understand that the predictive value of these tools might be compromised. I want to go back because I think I had one thing I wanted to add. No, this must be coming up. Sorry. Okay. Also, a really important thing to remember is that the child should be receiving accommodations during testing. I have heard parents one parent had a child who had a left hemispherectomy, couldn't see on the right, couldn't hear on the right, couldn't use her right hand. And guess what? The assessor sat on her right side. Another assessor did a neuropsychological assessment in a room with 2 or 3 white noise machines going. The child had a central auditory processing disorder. And you think, well, it's white noise. It's still noise. And the scores were really low. It wasn't an accurate reflection, in my opinion, of what that child could do or not do in that setting. So talk to the assessor before they do the assessment and say, this is how I think my child would do well. And remember, you're probably already breaking the norms of the assessment anyway. Most of the assessments I see, neuropsychological assessments in kids that have brain surgery, right at the beginning, the evaluator says, student couldn't sit still for the duration of testing, or we could only get 15 minutes of this, or whatever. Therefore, these results are an estimate only of their abilities. Really important to remember. I often hear families say, well, my kid is not testable. I'm going to talk about that in a little bit, but a good evaluator should be able to get something out of any child. And like I said, there are nonverbal measures. There are ways to gather information. There's looking at the history, there's interviewing the family and the teachers, et cetera. There's other ways to get that information. It might not be the full battery of testing, but that's okay. We're still going to get something out of it. So let's talk a little bit about how is this assessment different from all of the other assessments my child may have had. So those of you who have seen me speak before, or if you watch our webinar series that I mentioned on the IEP process, the comprehensive evaluation for a child after epilepsy surgery, which is what's required by law. So if you're doing it through the IEP process, they have to evaluate all areas of suspected disability. That can include many areas of assessment, right? So your child may have received one or all of the assessments on this list. I believe my son has received every assessment on this list over the course of his school career. I want to just point out the neuropsychological evaluation is going to offer a view of the whole child. But depending on their particular learning and attention issues, they may benefit from other evaluations. This is a list of all the different evaluations that might be considered for a child after epilepsy surgery. The neuropsychological evaluation will often be a catalyst for other evaluations. So again, and sometimes these assessments overlap because the neuropsychologist may measure things that fall into the domain of other professionals. So they'll generally, like I mentioned, they'll try to do a screening of auditory processing that might indicate a need for a full central auditory processing evaluation. They may notice sensory issues that would lead to an evaluation of a sensory disorder. Low scores on visually based reasoning tasks may reflect problems with scanning and integrating large amounts of visual information and lead to a more comprehensive visual assessment. They'll look at language function. And so therefore a speech and language therapist might be recommended to provide a more intensive evaluation or speech and language therapy. So the neuropsychological assessment does not replace the school district's obligation to evaluate the child in all areas of suspected disability under Child Find if you're using the IEP process for this evaluation. So the other question I get a lot is, well, my kid had a psychoeducational evaluation at school. Isn't that the same? So the psychoeducational evaluation at school, it tends to be done by a school psychologist who tend to be about a master's level of education. Some are more, but in general, that's the minimum requirement. They're interested primarily in whether the student's scores meet cutoffs for providing school services. Neuropsychology evaluations focus on determining the how and why a child performs the way they do. So they're going to look at the test result patterns. They're going to look at possible cognitive or perceptual disabilities in particular tasks, and they're going to understand those brain behavior relationships. Again, you see a lot of overlap with the neuropsych, and that's okay because the strengths and weaknesses are viewed from different angles to help give a complete picture. A psychoeducational evaluation alone would not be comprehensive for any child with a brain-based disorder. So my phrase that I use is if the child is seeing a neurologist, they need a neuropsychological evaluation. A psychoed eval alone would not be comprehensive. And you want to ensure that it's a very good neuropsychological evaluation in addition to the school district psychoeducational evaluation. You need both. The evaluations by school and clinical and neuropsychologists might use a lot of the same tests and measures. Sometimes families will get a neuropsychological evaluation from their children's hospital and an epilepsy center with a very skilled neuropsychologist and bring that to the school for their psychoed. And then that psychoeducational evaluator has to include the findings from that recent eval if it was within a year. And they also won't repeat the same measures that were just done on the neuropsych evaluation. So that's one approach to this. And the schools cannot diagnose medical conditions. They can only consider autism, ADHD, et cetera. It will not result in a diagnosis. So if you suspect something that requires a diagnosis, you really need to see a specialist who can diagnose. So that's ADHD, dyslexia, autism, intellectual disability, anxiety, et cetera. And the other thing you want is you want to know what tests did they use, and you want to know if they're appropriate for someone with your child's disabilities. Did they use the accommodations? Did they break the norms? And did they discuss that? So there is, a lot of language that's thrown around, and sometimes it can be very confusing. I'm going to talk to you in a minute about ways to get these evaluations. The school will offer the psychoeducational assessment. You may request a neuropsychological evaluation to be done as well. The school will not have a neuropsychologist on staff, so they may say, we will pay privately for a neuropsychologist, but it will actually be a clinical psychologist. So as long as the clinical psychologist understands the brain basis of your child's disorder and has some experience, because they have to be skilled and knowledgeable personnel to do these evaluations. Autism is a weird thing, and I think this might vary a little bit by state, but you might get a psychoeducational evaluation, a neuropsychological evaluation, and a clinical psychological assessment, and then suspect autism and ask the evaluator to opine on whether or not the child has autism, or even to evaluate, and they might say, I can't do that. You need to see this psychologist who specializes in autism to get an autism rule out evaluation. Sometimes that's even done by a psychiatrist, and sometimes it's done by a clinical psychologist. So I just want to clarify that a little bit. The other difference with the psychoeducational evaluation is that it's looking at measures of current academic ability and performance. It's how well is your child doing in school? How are they doing compared to their peers, as well as other skills necessary for school success. They should include an assessment of specific learning disability, in my opinion, but they may or may not. If they don't, and you suspect a learning disability, I would ask for them to reevaluate or ask for an independent educational evaluation, which I'll discuss in a minute. Just a reminder that that school-based evaluation is only related to school, and it doesn't identify the brain-based educational issues, and it doesn't address other domains of the child's life. So again, the reason why that neuropsychological evaluation is important. So hopefully you're all sold now, and you want to know, how do I get one? How do we get a neuropsychological evaluation? All right, so there's several ways you can do this. Probably the easiest way, and I guess it depends on your insurance and other factors, is to go through your insurance. My son, we were in San Francisco. My son is a UCSF patient, and they have a pediatric brain center. And in that pediatric brain center, they have neurologists, epileptologists, neurosurgeons, and neuropsychologists. And they understand, like I said, the ILAE says that it is an important factor for any individual who's had epilepsy surgery to have regular neuropsychological testing. Definitely before and after surgery, but ongoing. So you might be finding a neuropsychological evaluator within your children's hospital. Oh, here's the quote. Sorry, I skipped ahead. I said it without being on the slide. When we consider epilepsy surgery in children, we have to look at the impact on behavior and ongoing development, right? So again, if you don't have a clinician who understands the brain basis of the disorder, it's not going to be a full picture of the child. We want to give specific attention to assess the adaptive skills, the psychosocial skills, with appropriate testing, questionnaires, et cetera. So we want to be looking, a good assessor is going to look at activities of daily living. They're going to look at communication, social responsibility, autonomy at home, work, leisure, et cetera. I'm going to share the link to the reports that these are referenced from, so you can take a look at them if you're interested. According to the ILAE, a preoperative neuropsychological assessment should consist of standardized measures of cognitive function in addition to wider measures of behavioral and psychosocial function. So I don't know about you, but my son was 2 years old when he had his first neuropsychological assessment. And to me, it looked like he went into a room with a doctor for a half an hour, played some games, and came out. And how they wrote a report about that, I don't know. But for the younger child, a lot of it is play-based, observation-based, and then medical information and feedback from the parents. So again, that question of how are they going to assess my child when they can't speak or they won't cooperate, they assess very, very young children pre-surgery I think at very young ages, I don't know what the youngest is, but I wouldn't use that as a reason to not get an evaluation. So they should be providing a baseline. So we want to have something to compare to. It can be harder to establish a baseline for an uncooperative child, but it can be done. Pre-surgical assessment often helps the team decide if they are going to proceed with surgery. They're looking at seizure lateralization. So where are the seizures? Localization, where are they coming from? Characterization, what kinds of seizures are they? They predict cognitive risk of the surgery, including amnesic risk, which is memory issues, and then psychosocial outcome. And then they give feedback and education to the family. The post-surgical assessment should evaluate all aspects of cognitive and behavioral function that were assessed prior to surgery using reliable methods, and consider the nature of the surgery and the seizure outcome after surgery in the interpretation of these results, looking at the psychosocial outcomes, social, emotional, behavioral, functional, all of that, and then provide, again, a baseline assessment for outcome comparison and provide feedback and education to the patient and family. So this is looking at it from in the medical realm. So when we think about a school-based psychoeducational evaluation, we want to understand, does this diagnosis have an adverse impact on my child's education that requires special education and related services, right? So the school is obligated to evaluate your child in all areas of suspected disability. They do not have neuropsychologists, but if you ask for this evaluation, they need to provide it. And I'll talk about this in a second. So let's keep going here. Let me just see if there's anything I want to add here. I think that's good. Sometimes you'll hear that's medical. We don't do that here. So remember, child find, which is a very strong component of the law. The school is responsible to evaluate your child in all areas of suspected disability, and the evaluation must be done and trained by trained and knowledgeable personnel. So if there is someone at your school who is knowledgeable about the cognitive effects of epilepsy and epilepsy surgery, that's great. But it's very unlikely in that case they would need to pay for a neuropsychological assessment. You can ask for specific assessments, and the district has the responsibility to assess in all areas related. They can contract out. They may use the results of an available independent assessment, which I'll get to. So the way to request it, everything's always in writing. You want to list your specific questions, which I would say assessment questions needed. Sorry, that's a typo. Attach a letter from the child's neurologist or neurosurgeon, and then make sure that that is a specific request for a neuropsychological evaluation. Your letter from the neurosurgeon, again, in the follow-up resources, I'll be sharing a link to our website with a page that has a sample letter that you can use. But you want to explain to the IEP team why your child needs a neuropsychological evaluation. So you want to explain the etiology, which is the underlying condition that led your child to have epilepsy in the first place. What procedures did they have? What surgeries? And have they had any status events or other major events? What are the effects of the procedure on specific lobes of the brain and any other suspected effects? It's important to note that a letter from a neurologist or a neuropsychologist is not a prescriptive letter. They're not telling the school what to do. It's not a prescription, but it can help the school understand why this assessment is needed. Who assesses? This is the requirements for a trained neuropsychological assessor from that ILAE paper that I will be sharing with you. I'm not going to read this slide in the interest of time. And then reevaluation, I've always seen that a neuropsych evaluation should be done every 1 to 3 years until neuromaturation. And neuromaturation, which means when the brain is grown up, might be different for our kids, right? So it might not be the same age as a typical person. The school district will say every 3 years because that's when they're required. But if your child has a surgery, seizures return, shunt is needed, etc., any craniotomy, you should be requesting a reevaluation. And if you disagree with the evaluation, you can ask for an IEE, which is an independent educational evaluation at district expense. Again, this is explained in our webinar series overview on the IEP process. Do they have to consider an outside evaluation? So if you bring a private evaluation to the school team, do they need to consider it? Consider, yes. The law says they have to consider it. So sometimes considering it, and I'm doing air quotes, is reading it, saying thank you, and tossing it in the garbage, right? So I will also share an article about how to get your child's assessment more thoroughly considered in the IEP process. It can be challenging, but they do have to consider it. Another thing is if your hospital doesn't provide neuropsychological assessment, or you don't have insurance that will cover it, there might be a free or low cost assessment clinic, or work with a social worker at your hospital to see if have them help you get an assessment. And how will I understand the neuropsychological assessment? So we're going to look at a couple of evaluations now. Let's start with a 5-year-old assessment. All right, can I get a thumbs up or a vocal yes if you can see an evaluation now on the screen? You guys see something that says Neuropsychology Department Psychology Report? Is that showing up? Is anyone still with me? Thumbs up, thanks so much. All right, so this is a 5-year-old boy who had a hemispherectomy. And I'll have to tell you, to be perfectly honest, my son had his first neuropsychological evaluation at age 2 pre-surgery. And I want to say he had his second one around age 5, maybe even age 6. And I remember getting it. It was about 20 pages long, reading it, crying, putting it in a drawer, and not coming back to it for another year. Sometimes these reports are hard to read. So I want to acknowledge that and let you know I'm right there with you, sister or mister, right? This is tough. But the purpose of these evaluations is to get services for your child. It is a tool. This is not a picture of who your child is. It doesn't define your child. So I just wanted to say that before we step into looking at this assessment. So they're going to start with the reason for the referral. They're going to talk about which measures they used. They're going to describe the history. You will be receiving the sample assessments after today's session. And then they're going to talk about whether or not the assessment results are considered valid. And they also talk about the accommodations they needed. This was a very good assessment. All right, so they described that it was done in one session. They talked about how he benefited from breaks. I highlighted this report for the parent to say this is something that maybe this child needs in the school setting or in testing settings, right? If this is what he needed, if he needed to be able to move around, take breaks, go out and play, that tells us something that you can then say to the school team, I think this is something he also probably needs in his school setting. He was sensitive to overstimulation and loud noises. That's another thing you might want to tell the school. There were articulation difficulties noted. So is that going to be a goal, an accommodation, a service, or all three that might be needed? Do we need a referral for speech and language evaluation if that hasn't already happened? They're looking at intellectual functioning, which fell in the average range, nonverbal in the low average range, very similar to my son's report. So this was looking at it compared to previous assessment, that the attention had improved. Some things did fall below average, and then he had some stronger areas. So you're just going through this report and looking at what is this assessor saying about my child, and you're highlighting things that you might want to either ask questions about or talk to the school team about and say, how are we accommodating this? The child's not in school, maybe they're in a community setting, maybe they're in a work setting, and you want to understand these so you can bring it back to the supervisor or the school director or whatever it is and say, these are some areas of accommodation this child might need. Again, they're looking at comparison with prior evaluation. This I highlighted about the difficulty with copying when presented with P and B. This could indicate a dyslexia. So this evaluator doesn't look at dyslexia. So I would want to see a dyslexia evaluation after this. Let's see. This wasn't able to identify 2-digit numbers. So again, I'm like, is further assessment needed? Was this measure timed or untimed, etc.? Couldn't complete any phonics-based task, right? So we're looking at a child that had a hemispherectomy that had half their brain removed, including the auditory cortex. Most of these kids have a central auditory processing disorder, This child was too young to have been evaluated, and the evaluator doesn't comment on that, so it wasn't noted. But this is enough to say this is a challenge for the child. This would require intensive intervention in a quiet setting, and the child should also receive the auditory processing evaluation. So then they give the overall summary. They talk about generally comparing to the previous. And then the most important part of any evaluation is recommendations. So you're going to look at what is the evaluator saying is important for my child? And they're going to look at all settings, school, home, and community, right? That's the difference, one of the differences with a neuropsych eval. So they're saying this child is at high risk for difficulties in the academic setting. He will most likely require an educational setting that can provide a high level of individualized support and instruction. This evaluator recommended a small structured classroom. In cases where there is an auditory processing disorder present and such a significant deficit in basic reading skills and the phonics and phonological processing, phonemic awareness, et cetera, I would ask the evaluator to specify the size. Like, are we talking 1 to 4, a teacher with 4 students, or 1 to 1 for that reading instruction, right? So it's a little vague, but it's in here at least. If the small ratio is not possible, the child might benefit from a 1-to-1 behavioral aid. Again, that's a red flag for me, because what about learning, right? So sometimes the 1-to-1 is in there supporting behavior and attention, but is not a credentialed special education teacher that should be doing one-on-one instruction for learning. So that's really important. These are just some methods that might be used that you would highlight to the team: multimodal teaching, manipulatives, providing clear expectations, occupational therapy, functional writing skills, starting familiarity with technology. This is a 5-year-old, right? So if they're not looking at assistive technology, you want to get that happening. Again, the phonics task, and they talk about that. Specific concerns about attention and executive functioning, which is a huge area of concern in kids after epilepsy and epilepsy surgery. So she gives lots and lots and lots of suggestions about those. That speech and language therapy should continue. Be aware if the child's becoming overstimulated. Spatial issues were noted. This is also very common after epilepsy and or epilepsy surgery, because remember, we talked about the networks in the brain. The visual networks get disrupted, and then even if a lobe is not removed or disconnected, there can still be a disruption in that visual function, and a lot of these kids have visual spatial issues. Now it's going to be home recommendations here. So those would be things that you might be doing at home. This child's not really in the community yet, so we're not looking at community. Then there's going to be some follow-up. There's some standardized score test results, and some information about codes. So that's basically what you're going to see. I have other evaluations, but in the interest of time, I'm not going to go through them right now. If you have further questions, you can also always reach out to me. So the big question next is, what do I do with a neuropsychological evaluation? So a child with a neurological condition may not learn the way a typical child would, even a child with another type of disability, right? Again, the reason for a neuropsychological evaluation. So the standard learning interventions that the school team might be familiar with as an intervention for a student with a common disability, like a speech disorder or maybe a language-based disorder, dyslexia, or whatever, those interventions may not work for a child with a neurological condition, underlying neurological condition. So the neuropsych evaluation can help inform appropriate direct services, educational goals, and accommodations within the school setting. This is your tool, right? Don't be afraid of it. We often request these assessments because we want more information about the child's cognitive status, their behavior, their emotional status. We want to understand their problems, their strengths. We want to develop a plan for treatment. We want to understand if they meet criteria for certain disorders, right? That diagnosis piece, which might make them eligible for certain kinds of services. And it can also be helpful in assessing treatment effectiveness. So when you look back at the previous eval, the neuropsychologist might say, you've been using X reading intervention for 2 years, and in my assessment, the child's reading is at the same level as it was 2 years ago. You might consider X intervention instead, or you might consider one-on-one instruction in a quiet room because the auditory piece is really interfering, or whatever it is, right? So the neuropsych assessment is going to help you identify disabilities leading to a diagnosis, monitor change in cognitive functions in the developmental level that might be related to the underlying disease factors or the treatment factors. Recommendations should include home, school, community, medical, allied professionals, agencies. At transition age, these evaluations are very, very important. What are the supports and services that this child requires in any setting? What are the best interventions and treatments? Is the student eligible for things like extra time or other accommodations for standardized tests? So those of you who have kids that want to go to college, the neuropsych assessment could indicate the need for specialized testing accommodations for the ACT or the SAT, or for school-based testing accommodations, or even work-based testing accommodations. The neuropsychologist should be ensuring that the current curriculum and teaching strategies and behavioral management techniques are appropriate for the child, right? If possible, they should be observing the child in their setting. They also want to make sure that you're providing the best support at home to help your child learn, and then also setting reasonable expectations. One of the questions I get a lot from families when they call me to talk about an issue, they ask me, is my child going to achieve X level because they had X surgery, right? I have no idea, right? And your doctor, your neurologist, and your neurosurgeon probably doesn't either, but the neuropsychologist can start to tease some of this out and say, look, your child is very strong in this area, not so strong in this area. So for example, my son has very poor spatial skills, visual spatial skills. So he was encouraged not to take geometry, right? So there's things that we can learn about our children that are only really available through this assessment. Don't be afraid of the neuropsychological evaluation. It really, really is an important tool. I know sometimes it's scary, but information is always good. So that's all I have. I know we only have a few minutes left, but I'm willing to stay over for questions. You can also email any questions for me. So if you have any questions, none came up in the chat during my presentation, but if anyone has any questions, you can pop them in the chat. And if you have a question you'd like to ask off camera, I will stop the recording in a few minutes. Does anyone have any questions, or did I thoroughly overwhelm you? All right, I'm going to go ahead and stop the recording, and let's see here. Where are my other options? Because maybe some of you, what age do you recommend for an assessment? I don't know what the youngest age norm is for neuropsychological assessment. I should have researched that before coming in. Like I said, my son was 2 when he had his first evaluation because he was about to go in for epilepsy surgery. And again, it's recommended pre-surgery that the child have a neuropsychological evaluation to set a baseline, to establish a baseline. I think down to maybe age 1, but I'm not exactly sure, so don't quote me on that. There's not a youngest age or an oldest age. It really, again, depends on what is the question you want answered with this report, right? We talked about a lot of different ways that this report can be used. Let me go back to that slide. So are there any areas here that you want to learn about? And so that's where you would be, why you would be deciding to do an evaluation. Like I said before, in terms of repeat evaluation, about every 2 years for a child with a brain-based disorder, you want to repeat the evaluation. In our case, I think we did it about every 3 years because there were other things going on, or we didn't feel like we needed an update at that time. And every evaluation, I learned something new. My actual reports are dog-eared and have like 10,000 sticky notes on them and highlighters in different colors. And I always had multiple copies of them and would hand them out to people in different settings. And this is literally from preschool into now my son's in college. So his last neuropsych eval went with him to college to get him services in college. He's working with adult agencies like the Department of Rehabilitation in our state. They have a copy of his neuropsych that I can use as the basis for receiving services and getting accommodations. So it really, it's a really, really important tool. You want to use it throughout the child's life. Are there any other questions? All right, I'm going to stop the recording now. Thank you for joining us today.